Thank you, everybody, for coming today. My name is Jane Nathan, and I want to welcome you all to the endowed Laura Mann Integrative Healthcare Lecture Series and Neuroscience Grand Rounds. Before I begin, I want to announce that Dr. Helen Langevin will be presenting at the Community Integrative Practitioner Forum on connective tissue, stretching, inflammation, and musculoskeletal pain on March 14th at 5:30 here in Davis, and CMEs are available. I'd like to start with just a little bit of history about Laura Mann. She was a home birth nurse midwife who served her patients with great compassion. When she was diagnosed with stage 4 breast cancer, she learned to thrive by integrating Western medicine with complementary and alternative medical therapies. She created a center devoted to promoting the benefits of integrative healthcare to others. Despite her untimely death, Laura's vision is alive through the endowed Laura Mann Integrative Healthcare Lecture Series, which brings distinguished leaders like Dr. Mehta to the University of Vermont to share best practice, research, and innovations in integrative healthcare. The series is sponsored by UVM Integrated Health, a collaboration between UVM College of Nursing Health Science, the Larner College of Medicine, and UVM Medical Center. So it's my pleasure to introduce our Winter 2017 Laura Mann Integrative Healthcare Visiting Professor and Neuroscience Grand Round Speaker, Dr. Darshan Mehta, who will be presenting today on Mind-Body Medicine, Emerging Science and Economics. Dr. Mehta received his MD from University of Texas Southwestern Medical School and recently completed, well, relatively recently we just learned, a Master of Public Health from the Harvard School of Public Health. He is the Medical Director, Director of Medical Education, and Staff Physician at the Benson-Henry Institute for Mind-Body Medicine at Mass General Hospital. He is also the Associate Director, Director of Education for the Osher Center for Integrative Medicine at Brigham and Women's. In addition to teaching at Harvard Med School and directing medical students and residents in health profession training, Dr. Mehta sees patients in a consultative role for use of complementary and integrative medical therapies and mind-body interventions focused on stress management and reduction. Dr. Mehta has had an active role in the ongoing development of the Benson-Henry Institute's Stress Management and Resiliency Training Program, referred to as SMART, a training offered in various designs for families, patients, and healthcare professionals. With the help of Dr. Mehta and the Benson-Henry Institute, the UVM medical family is learning more about best practice and how to advance mind-body medicine here to reduce stress and create resiliency for our patients and families and our healthcare providers from student to physician. We are currently piloting the 16-hour, 8-week SMART program involving 20 participants invited from UVM Medical Center, the College of Nurse Health Science, and the College of Medicine. The program is being delivered by faculty from the Benson-Henry Institute, and the pilot is working in partnership with Employee Wellness at UVM Medical Center, generously financed through a special wellness fund through Blue Cross Blue Shield of Vermont. We had the privilege of having Dr. Mehta lead our training this morning, and I've personally been honored to do direct training with him at the Benson-Henry Institute, learning to deliver the SMART program in various forms. I assure you, you're in for a wonderful presentation. Please help me in welcoming Dr. Darshan Mehta.
Thank you, Jane. Thank you, Kara, for having me here, and Evelyn as well. Thank you. It's really, truly an honor and treat to be here. It's my first time here at University of Vermont Medical Center, and I'm truly jealous. It's such a beautiful space, and just this ambiance is just amazing. So it's inspiring me personally as well. So I'm just grateful for this opportunity to speak in front of you. I'm hoping in this time together, and then I'm going to have some remarks, and then I would at the end hopefully we'll have some time for some questions and a little bit of discussion around thinking about this work critically. That's the important piece. This is really, I want us to think about this work critically because I feel this work is critical. It is so fundamentally important to the well-being of ourselves as healthcare providers. It is so fundamentally important to our well-being of our trainees. It's also, and most importantly, important to the well-being of our patients. And I really genuinely hope that when we begin to sort of think about how this type of work it really fits into the construct of a modern system of medicine that incorporates the best of what surgical practices and procedure-based opportunities we have, as well as pharmacologic management, as well as individually provided care. So my disclosure statement. This is my disclosure statement. This job has cost me my health, my family, and my soul. Can I get a receipt? This is generally, sometimes many of us in the healthcare professions, we feel this way. I mean, it's such a long journey to get to where we've gotten to, and we still feel like, God, we're still like plowing through these trenches and really not making much progress. But it affects, obviously, because of the passion that we have around this work and the work that we do in the care and service of our patients, it impacts the people that surround us and the people that love us and the people that we love. And so this sort of thinking about balance is important. And I just want to sort of honor that, acknowledge that. What I hope to cover today is a little bit of some of the definitions. It's important to have sort of a lot of these words that we see in mind-body medicine are often used flippantly. And I want to just provide some sort of common denominator. Some emerging research, and again, I use the word it's emergent research because there's nothing definitive. I can tell you right now, there are no like absolute conclusions drawn. There's nothing, this is not the panacea. It's not going to cure everything. But I want to talk about where things are emerging, where things are exciting, where are some of the opportunities for the sort of the next generation of this work, and then talk a little bit about our clinical applications. One of the interesting dimensions of this field, I'll just say at the outset, is this has been largely and historically patient-driven. And part of it has come from, you can see this this was one of my first exposures into this field. I came across this article. This was in the middle of my residency. You can see, you can't see the date, but it's 2003. And it says, how your mind can heal your body. And the subtext is, new ways to beat the blues. The link between mental and physical health is happiness in your genes, women, men, and depression. So again, you can see that already there's this sort of tone, and this wasn't unique to that year. This has been going on for some time, and I'll show you examples through my talk. So there are many influences for me as to why and how I've arrived into this field. Some of it's been my own personal journey, family influences, support of my siblings, my wife, in sort of pursuing this field. But one of the biggest influences has been my patients. And one of my patients, and again, as was mentioned, I was trained in internal medicine and primary care. And it was in continuity clinic in residency. It was a 35-year-old male who presented with no significant past medical history, came for a routine physical. Family history was significant father dying of lymphoma, mother with long-standing hypertension. Social history was recently married, worked in the IT industry, requiring a significant amount of travel, and due to the travel, attended a lot of fast food, denied any tobacco, alcohol, or illicit drug use. Now, already one of the things, you think, oh, this is, for those primary care, and if there are residents in the crowd, especially those in any primary care specialty like family medicine or internal medicine, you say, oh, this is the great patient. This is like, I wish my whole panel was like this type of patient. This is like the easy stuff. I was thinking that, but I thought, oh, there's some clues here. You can see, okay, something fast food, eating a lot of fast food. If we go to physical exam, BMI 31, so elevated. Blood pressure 135 or 90, so again, elevated. Otherwise, no remarkable findings. Labs were significant for the HDL being 41, LDL 148, so slightly elevated. Triglycerides 150, borderline. Fasting plasma glucose 120. So the assessment was, hypertension, the word metabolic syndrome, it was actually previously called syndrome X. It was just sort of entering our language at that time in the clinical side. So wasn't really quite sure. I I only had a few tools at my disposal, some medication. So let's start some medication. High blood pressure. Maybe we need to reevaluate for maybe you have some insulin resistance, diabetes, the triglycerides, and this sort of higher LDL value. He said, no, don't want any of that. So I did diet and exercise counseling. Now, what's the diet and exercise counseling I learned in residency? Diet was you tell a patient, eat less. That was it. That was my diet counseling. And exercise was walk more. That was it. That was the extent to which I did my diet and exercise counseling. And that was what we were taught. We weren't really taught more beyond that, but you tell them that. There was other counseling I thought, that I had learned, because in medical training, at least, again, the covert culture was the best way to motivate someone is you scare the living daylights out of them, right? You tell them about every possible bad thing that can happen. So you said, you're going to have a heart attack, you'll die, you'll have a stroke, you're going to, have this cancer and that cancer. And for men, if you tell them, if all this happens, you'll develop erectile dysfunction, that should change everything, and that should be the biggest motivating factor. But no, that wasn't even, but obviously that may work in a small percent of population. It turns out it's actually a very ineffective way of motivating someone is to scare them. Some people, you have a life-changing event, and that might do it, but in this case, so he decided to counsel me. And he said, Doc, I appreciate what you're saying. It was very nice. He said, but I want you to share with you something I've read. What do you think about this? So he brings this in. And again, this is, just to show you, this was right in the middle of my residency. It's August 2003 Time episode. It says, New Age mumbo jumbo, not for millions of Americans who meditate for health and well-being. Here's how it works. The science of meditation. And anyone recognize who this is? No one? No one. This is actress Heather Graham. It says, who's been practicing transcendental meditation since 1991. It says, Doc, what do you think about this? So it's interesting. A lot of things came up for me. First of all, it's like meditation and medicine. One mentor of mine said that if you look at the roots of those words, actually turns out they're the same roots of the word meditation and medicine. If you switch one letter, medication and meditation only differ by one letter. And if you think of the third thing, it's like, do you have to look like this to practice this? Is what this is all about? Like, you have to have this sort of ethereal, angelic-looking sort of posture, sort of sense of particular body image, particular sort of phenotype. That's sort of one of the things that really got me interested. It's like, is this what this is about? It got me interested in the field. So that's how I've arrived. And it began to actually help me think about what does it mean when I understand someone's stress and stress physiology. And so when we think about stress physiology, the word became thinking about what is this concept of stress from a patient perspective, and then what does it mean on the clinical side? Because we use the word stressed all the time. I'm stressed. I'm stressed. It's like this negative thing in my life. You never say, I'm stressed, like in a positive, like it's hardly ever used that way. But yet we know that physiology of stress is not necessarily a bad thing. But to give you just a sense of a little bit of the vocabulary I began to sort of uncover, we all have stressors in our lives, right? So stressors include things like family relationships, disagreements, money worries, this need to succeed, exams, friends, decisions, new situations. And out of that arises this sense of alarm. And I'll go through this in just a little bit, but Walter Cannon at Harvard Medical School, he coined this term, the fight or flight response, right? You either fight or you run, and then you return back to normal. And again, remember, this was a physiologically advantageous survival mechanism for us. It was necessary for survival. If a bear is in front of you, you're not going to survive if you sit down and meditate. That's not going to help your survival. And so you had to have these mechanisms were placed for a reason. And in prolonged situations, you had to develop abilities to cope and coping strategies, which allowed you to return to normal sort of homeostasis in terms of your physiology. But if you weren't able to cope, you began to develop inappropriate responses, negative thoughts. You had poor diet, lack of exercise, hypertension, irritability, debility, and then exhaustion, and then for some people, based on their genetic predispositions, they had disease or overt breakdown. Okay? And so what allowed us to go on the path of returning to normal physiology versus returning, the other path? And to look at this just a little bit differently, if you look at some of these other factors, again, when we look at the brain, the brain, again, this is a neuroscience talk, so I had to focus a little bit on the brain. The brain is the central sort of, that's the prized organ in our body. Now, again, in intro medicine, as we all know, depending on what subspecialty, and you will all argue that yours is the prized organ. But in this case, we think about developmental history, genetic variations, sort of nutrition, aging factors, that impacts the health and well-being of the brain. Our brain is sort of the epicenter of our stress system. So, and we have two sort of main, again, this is a intentional gross oversimplification of the pathways, but there are two main pathways for you to think about. The hypothalamic pituitary axis, which again, you have release of cortisol, growth hormone factors, insulin growth factor, TSH, again, which impact target tissues. And on the other side, you have the systemic sympathetic adrenomedullary system. So you have things like norepinephrine, epinephrine, again, interleukin-6. Again, all these impact the target tissues. When they do impact it in this sort of, in a mass way, you have the emergence, again, based on the genetics, of stress-related conditions, including metabolic syndrome, endothelial dysfunction, conditions like polycystic ovarian syndrome, osteoporosis, penia, atherosclerosis, cardiovascular disease, etc. But ultimately, it goes back to thinking about the patient experience. We have to reflect back. Again, this is all physiology, and it's about thinking about physiology here. And pretty soon we're going to move into sort of thinking about what does it mean for the individual. They're not thinking about this, all these hormones and all this. They're thinking about this. So this is a slide I use when I give a talk on sort of residents and resident burnout. But obviously for residents, and medical students, oftentimes, these are the things that they're directly thinking about. Life situations, achievement, changes in finances, work hours, illness. You have, when do I even retire? When do I start work? Are the things that we think about. There are organizational issues, again, that we want to think about. What is my role in the organization? Again, this is a multidisciplinary crowd here. Where do I fit into this organization? What is my status? What are my relationships at work? Career development issues, hierarchies, homework interface. Again, for an organization, the worst thing that can happen for patient care, apart from making an error or delivering poor, is if you don't show up for work. You can't deliver patient care if you're not there. And again, this is one of the things that we think of that results in higher costs, dysfunction, litigation, et cetera, which are the things that administrators and sort of leadership at a systems perspective are thinking about. We can't have these high costs. Certainly, we don't want to have a reputation of being bad place for healthcare. And the last thing is we don't want dysfunction between all the different types of healthcare providers that are necessary to do the care that we deliver. But again, I want to step back again one moment. Not all stress is bad. When we use the word stress, it's not a bad thing. And this is Yerkes-Dodson law from the sort of business world. Ideas think about where is your optimal sweet spot, and how do you know your sweet spot? So obviously, we always think about the high end. That's where you burn out. There's fatigue and sort of exhaustion. By the low end, if you don't have something that sort of pushes you and moves you, you are bored. There's no space for creativity. It just, you just sort of, there's a monotony in life. So that sweet spot is where we thrive. And understanding really what we are now moving, the language of this, and the language that we have started to use with patients is how do you move from survival mode, which is how we've thought about stress, to thrival mode. From surviving to thriving is how we want to start to think about this notion of stress in the modern healthcare context. Dr. Benson, who some of you know has been my mentor for over the past decade, he always quotes the statistic And I had to then ask him, between 69% of healthcare visits are really, I had to ask, where did you get that statistic? I have to, when I give a talk, I need to give that reference. And he couldn't locate it because he had, his original slide was this Kodachrome slide that he would, put in. And so he didn't have it on that one, and he couldn't find it. So it bugged the heck out of him. So then he said, you need to find it. So I went digging. It took me about over a week to find this, but I found the article, 1964 article, by actually interesting, it happened to be at MGH, and by a famous primary care provider, some of you may know, Dr. John Stokel, who published a study and basically cataloged why people arrived in the clinic. And turned out that's about 69% of ambulatory visits were related to psychosocial stress. And so that's probably true today. The study has not been replicated in the same way that was then. And so, but I suspect those of you in whatever field of medicine that you're practicing or are involved with will probably say, yeah, that's probably the same today as well. And every audience that I've shown the slide has agreed with this concept. So that's where this field of mind-body medicine has now come, has evolved. It's out of this specific needs, these specific needs that we talked about. So what I want to now take you through is a historical, contextual journey of why does mind-body medicine look the way it does today? Because I think you have an appreciation of why it looks the way it does. You'll understand where it's going moving forward. And there's several themes that are here. And these are themes I've adapted from Dr. Ann Harrington, who's professor of history of science at Harvard University, who's written about this, but really a thematic approach in thinking about mind-body medicine. And there's 6 themes: the spoken body, power of suggestion, stress in modern life, power of positive thinking, healing networks, and Eastern journeys. And I'll explain each of them in a moment. So the first one I'll cover is stress in the modern life. It says, hard-charging businessman Billy Sloan is about to learn that continued stress does inhibit one's memory. I'm sure some of you have had this experience on more than one occasion. This idea of the word stress in the modern life has been around for some time. You can see this is an article from, again, you can see the lay press has been all over this for decades. 1983, stress, seeking cure for modern anxieties. So one of the first words that was used around this word of stress was neurasthenia. President Theodore Roosevelt had the diagnosis of neurasthenia, turns out. And how did he treat his, does anyone know? How did he treat his neurasthenia? Yeah, hunting, exactly. That was his treatment of his neurasthenia. And it turns out, in order to do that, you needed to have a safe space to do that, right? Without injuring somebody else. And that actually was one of the key reasons, not the only, but one of the key reasons, the impetus for our national park system. He needed it, as many of you know, we just passed the 100-year last year was the 100-year anniversary for the National Parks Service. And it was in his presidency that it was created. And so that was part of the reason. As I mentioned earlier, fight or flight response, again, that was another word that was sort of talked about as and Dr. Walter Cannon at Harvard University Harvard Medical School really sort of described this physiology. The question became is this an evolutionary advantage or disadvantage? And because it wasn't quite clear, is this bad or good for you? And what makes it good, and when is it good, and when is it bad? Hundreds, if not thousands of studies have looked at this, and there's no clear consensus. But here are some of the things that we know. Well, one of the things is it's operationally difficult to understand, the operational construct of stress. And Richard Lazarus and Susan Folkman, who some of you know, have been some of the eminent scholars in thinking about this. Stress is a process in which environmental demands tax or exceed the adaptive capacity of an organism. It may result in psychological and/or biological changes that may place persons at risk for disease. So stressors are environmental experiences. Appraisal are our subjective evaluations of the stressfulness of situations. Again, appraisals can be different, as we can appreciate. And that concept didn't hit home for me until I bought my first home in Boston, and what it meant to, in the midst of the housing market crash, and what was appraisal. And that mattered in terms of whether I got a mortgage or not. And there were different evaluations of the same situation. And the stress response are the affective, behavioral, or biological responses to stressors or appraisals. So this is Hans Selye, who is a famous, from Montreal. He really thought about sort of what is then, if the stress response or the fight or flight response really was about one point in time, what does it mean when you have this over a lifetime? Some of the early links, some of the literature is thinking about this link between type A personality and coronary disease. How many of you consider yourselves type A? Come on, you can be honest here. Good. Okay, good. So it's interesting is type A was linked to this sort of coronary disease and said, oh, that means you're at higher risk for heart disease and heart attack. But the funny thing is, and actually that literature hasn't panned out to be as true as it once thought. We've actually forgotten what type B and C personalities were. Those were all part of the study too. But type A has still remained in our language. Stress and the link to the immune system. Again, the idea that somehow when you're under chronic negative stress, that impacts your immune system. So again, there's a cumulative effect over the stress over the course of a lifetime. And so this is Sheldon Cohen's work. Again, what he did, he took, at University of Pittsburgh, he took a group of medical students. When medical students, you offer them money, you offer them a hotel room and some food, they'll do anything. So he did, and he basically, he was evaluating this idea of what is someone's subjective stress and how does that correlate with their immunity. So he did a prospective study, he randomized them, he gave them inoculated with them rhinovirus, so the common cold, and then he saw who developed the cold and for how long. And you can see here clearly by in terms of the observed, the more stress that they reported, the percent of subjects with infection increased. And this was one of the first studies, and obviously published in New England Journal of Medicine, to demonstrate that there is something here between someone's perceived stress and their immunity, and hence the development of the perceived stress scale, which some of you are quite familiar with. Bruce McEwen at University of Rochester has also talked about this concept of allostatic load and allostasis. So homeostasis is sort of at a point in time, this equilibrium that you live in. Allostasis is the ability to shift between. So when you are in a stress response, you're able to mount the stress response when a stressor is in front of you. And when that stressor is not in front of you, you're able to actually return back to normal physiology. And that ability to sort of shift is what we call allostasis. So when you have increased allostatic load, when you take into account individual differences, your major life events, trauma, abuse, environmental stressors, your behavioral responses, you actually lose that ability to adapt. Okay? And so this has now been explored and that has consequences. That inability to adapt is sort of like thinking like a rubber band. Once the rubber band, there's three things that can happen with the rubber band. If you stretch that rubber band too much, it completely, breaks apart, or it becomes limp over time, right? If you keep stretching that rubber, it just becomes limp, or it retains its tension, right? So there are three options that happen. That's actually depicted here. When you have repeated stressors, lack of adaptation, a prolonged response, and no response at all. So that's sort of emergence of stress in the modern life. Next theme, power of suggestion. A beautiful study done, published in JAMA about a decade back, and basically it basically told patients, we're going to shock you with this device, and then we're going to give you this pill that will mitigate the response that you experience. And just let us know how much you do it. The difference, though, is, the two is that round one, you'll be given the regular price stuff, and round two, the cheap stuff. What they didn't know is they were all getting placebo. There's no difference. Okay? So it's only what they were told. And you can see that as shock intensity increases, in general, the response to getting the regular price versus the cheap stuff increases, widens. How much difference they respond in the shock intensity. So again, the power of suggestion. This is pain, for pain management. So that means that, again, this is something I teach medical residents, students, and other trainees all the time, is that the way we talk to our patients actually matters. I'm going to show that even in a subsequent study here in a moment. But how we say what we say actually makes a difference in how people experience what they experience. So what is it? Ron Epstein has beautifully talked about this. He calls this concept of the mindful practice. Some of you, again, may be familiar with his work. It's to become more aware of one's own mental processes, listen more attentively, become flexible, recognize our bias and judgments, and thereby act with principles of compassion. To have an ability to observe the observed while observing the observed in the consulting room. That means knowing where you are in relation to the person who's out there in front of you. And this type of thing isn't something that just people are innately born with. It actually requires mentorship and guidance. And so this type of work that he's done and others like him have done has become the impetus for why we do the work that we do with medical residents and students currently. And it's been sort of this real huge push, as many of you know, to really work at the level of the trainee. Next, power of positive thinking. This study done by my colleague and mentor Ted Kapchuk. Again, some of you know, he actually basically took a study of patients with irritable bowel syndrome, randomized them to receiving what they were told acupuncture treatment versus a placebo pill, and then really was focused on the acupuncture arm. And I'll show you what happened on the acupuncture arm in this particular study. It says, I want you to take this placebo 2 times a day for 10 days. If your condition doesn't improve, I'll give you a stronger one. So what he did was, in the acupuncture arm, he was interested in what are the components that make a difference in the way that people think and perceive about their outcome. And so he sort of think about, well, what if you just get the study? The fact that you're in a study. And irritable bowel syndrome at this point, and still to this day, we have very limited pharmacologic options. When this study was conducted, there were none. The one that was approved when I was a resident had been pulled off the market because of side effects. And so there was nothing really offered for this patient population. So he said, well, you're going to be in a study. Okay? And so he decided to look at them. They were given a nice intake, and then he looked at them, you know, down the road. Then the second arm was a scripted encounter with the acupuncturist. They were told that they were laid out, here's what you're going to say, here's what we're going to do, and then if you have any questions, please contact the study coordinator or the principal investigator for anything else. So a very scripted encounter. So the idea that, remember, arm 1 was you might get something, arm 2 is you are getting something, but in a sort of the ritual. You know, it's like sort of if someone comes to me for knee pain, I'm just listening to their heart and lungs, because it's just my ritual as an internist to listen to their heart and lungs, even though they came to me for knee pain. The third piece was what he terms as the empathetic encounter. So really, he had sort of 5 different cues that he wanted to make sure that in every encounter it hit, whether it was eye contact, affirmative language, and he had a whole sort of multiple cues that the activator. So, basically like, how are you doing? Tell me a little bit about your pain. All these things that we teach those of you who are medical student educators, when they learn interview and communication, we ask them to master, right? And not sort of nonverbal communication, verbal communication, open-ended questions, all these things that we think are very important for the therapeutic encounter. And what did he find in this condition? When he looked at outcomes, again, 6 weeks out from it, you can see that just being the fact that you might get something improved. The fact that you got something like just an encounter improved it a little more, and the fact you got the augmented or empathetic encounter improved. You can see that in most of these, this is a metric, a global scale that's used in IBS studies, and you can see this, and it was sustained even after the trial ended, so immediate post. So this was. Here's the kicker. This outcome, if you had put in a drug and not told and blinded the FDA, these results would have been used to approve the medication. Okay? That's what the clinical relevance of this is. So interesting, right? So what does it say? It says, Susie, I thought you were sick. You look great. I feel great. I took some organic kombucha, algae, honey sport tincture, cleared my up. Try it. What? That stuff doesn't work. There's studies magical. There's junk science. Stop it. You're ruining my placebo effect. It says, ignorance is bliss, huh? It's my healthcare plan. So, what does this say? No, it's not to say that we want to deceive our patients. It's to say that the way in which we work with, talk to, interact with our patients is so important and actually facilitates their treatment journey. And that means that that's just as important to, in addition to whatever drug we might prescribe them or whatever procedure we might want to do for them, because it may help augment their outcome. The next theme, healing networks. Anyone know the story of Roseto, Pennsylvania? No? Okay, Roseto. No, well, not quite, but I'll tell you. But it has to do. It does have to do with longevity. Roseto, Pennsylvania, is a town in central Pennsylvania, and in 1950 they looked at this town and said, "Wow, they're living 10 years longer than the adjacent towns. What's special about Roseto, Pennsylvania?" So they went in, and this is, as you can tell from the name, it has an Italian origin. So this is but it had been several generations. It's been 3-4 generations in. But Italian immigrant community. The adjacent towns were German. These were coal mining towns. So maybe smoking rates are different. No, it was equivalent across the board. Maybe it's the occupational. Obviously, they're all coal miners. Maybe it was the diet. This was like the Italians. They had that. It's that Mediterranean diet. And that is it. But by this time, they'd all moved, converted to the SAD diet, right? The standard American diet. So it wasn't any of these factors. The one factor that differentiated this was this concept of the healing network. And they identified this factor as such that they lived in multi-generational homes in Roseto, Pennsylvania. And because of that, when somebody in the community fell down, literally fell down, like broke a leg or something, the whole community came and helped that person. And that's what happened. Whereas in the adjacent towns, that wasn't happening. Interestingly, they looked at this community in 2000. It was like the 50-year, look and what happened. And by this time, people had shifted out of the community and stuff. And all life expectancy difference has equilibrated. Doesn't exist anymore. So healing networks, the idea. So when you think about someone who's in chronic illness or chronic pain or chronic whatever, put in whatever specialty you're in and put in your chronic thing. What is the most common thing that people describe? No one gets me. I'm isolated. And so why is one of the themes in mind-body medicine has been in these these are creations of micro-communities that actually help create a sense of community, that someone is lifting me up without knowing that I'm being lifted up. Next theme, Eastward Journeys. So again, mind-body medicine, one of the interesting things about it, it's really about a counterculture movement that emerged in the 1960s and 70s. I do give the Beatles a lot of credit. They were looking for an alternative experience to LSD and a hallucinogen, and they went off to India and they found this yogi by the name of the Maharishi, Mahesh Yogi, and it inspired one of their albums, as some of you know, when they returned from that sort of spiritual retreat. But there are other important people, I think, figures that happened in the 60s. Some of you know Paramsa Yogananda, Autobiography of a Yogi, he wrote, Thich Nhat Hanh, J. Krishnamurti. They're non-Asian mystical practice, so in other centering prayer is in sort of the monastic traditions, particularly in Catholicism, Kabbalah, Sufism. So again, all these sort of things emerged, the idea of moving toward the East. But the Maharishi, I just want to put a specific, obviously, again, you can see that's him. It's a meditation, the answer to all your problems. He really moved from Woodstock, he was at Woodstock, and Beatles to science and physiology. And he leaned upon this guy named Dr. Herbert Benson, ultimately. But he was a believer that approach, transcendental meditation, was sort of this discovery of this fourth major state of consciousness. There are other important people who some of you know. That's Jon Kabat-Zinn, very important luminary in the field. And I say Bill Moyers had a huge impact on this field. He had this series in the 90s, a very popular PBS series called Healing in the Mind, and it catapulted people like Jon Kabat-Zinn into this public arena that they were doing their own little thing. Jon Kabat-Zinn, for example, was University of Massachusetts Medical Center, doing his own little stress reduction program in the basement, as he always described the story of the hospital, and no one knew about it, and this catapulted him into this really into the limelight, and it's exploded. He wrote this famous bestseller, some of you probably read it, Full Catastrophe Living, created this program called Mindfulness-Based Stress Reduction, or MBSR, Origins are in Buddhist meditative practices, and it's really characterized this, he calls this psychological state of intentional, non-judgmental present moment awareness. There's also what I call the Dalai Lama effect. He has really created a culture where there's dialogue, or has invited a culture between scientists, and particularly neuroscientists, especially neuroscientists. That's Richard Davidson, eminent neuroscientist at University of Wisconsin, and contemplative practitioners and theologians, as well as other disciplines. So it's really this interdisciplinary, cross-disciplinary dialogue that has happened. So this is what happens now in our clinic. I'm learning how to relax, doctor, but I want to relax better and faster. I want to be on the cutting edge of relaxation. Okay. So what is it that's going on? So mind-body medicine, as my mentor, Greg Friccione, he really sort of described this equation, and that's what we're at in our research side, are really trying to develop an understanding. That when we understand someone's stressors or their allostatic load, and we account for their resiliency and social support factors, we can actually, just like we do the Framingham risk calculator, we can have someone's selective vulnerability, understand their propensity to illness. The flip of this equation is understand someone's propensity to wellness. Obviously, mind-body medicine is very prevalent. Almost now, it's the fastest growing sort of complementary and integrated modality out there. I'm giving you the tip of the iceberg of the literature because we don't have the time, and that would be sort of a symposium that would happen over weeks to go over all the literature. What has shown in different sort of reviews and such is it reduces frequency of medical symptoms, it decreases the severity of psychiatric symptoms, and increases health-promoting lifestyles. The first two, they're great. The last is where we have amazing opportunity. When you allow someone to take personal health responsibility in a way that is encouraging rather than discouraging, that is where I think is where our opportunity lies. And why do I say that? When we look at costs now, and I'm going to show you some cost data that is going to, I hope, surprises you. We were contracted by Medicare about a decade back. Our program, they had heard, has a big mind-body program in our cardiac rehabilitation program. And they thought, well, you guys are investing, you spend more dollars. Why don't we pay you a little bit more and see what happens? So we took moderate to severe coronary artery disease sufferers who were qualified for cardiac rehabilitation. And then we looked at them at 3 years. And we found that three things when they went through our program compared to when they went through traditional rehab. They had found comparable patients in the Medicare database, as well as they didn't do anything. You got decreased mortality. So ours is 3% mortality at 3 years versus 10% in both of the other arms, traditional rehab, as well as doing nothing. It sort of begs the question, what happens in traditional rehab? It increases time to rehospitalization, which is a metric that all hospitals are being looked at. Like when you come, you don't want to be coming back for the same reasons, right, to the hospital. Otherwise, you get penalized now, or they don't pay you. And reduces costs. So we will show that it reduced by $3,000 per Medicare beneficiary. So that has created a new code. I don't know, some of you may know, there is a new code called the Intensive Cardiac Rehabilitation Code in Medicare. It's the only code that requires peer-reviewed journals to get reimbursement for that code in Medicare. It's an interesting code that they've created, but there are only 3 programs in the country that have that code. Ours, the Ornish program, Dean Ornish is working, some of you know, and then the Pritikin program that have the ability to use this code. And again, as I mentioned earlier, Dr. Benson, it was really, the followers of Transcendental Medicine really approached him initially early on. He gives this wonderful story of where they would pester him, and he refused, and they keep pestering him, and he reviewed and finally relented. And he ended up studying them, and he learned that there was a specific physiology that was really distinct from any other physiology described in the literature when they went through their practice. And he coined that term as relaxation response. When he began to look at other approaches, he found that this physiology was found in other mind-body practices in addition to transcendental meditation. And so he really said the conditions by which it's evoked are repetition of words, sound, prayer, thought, phrase, or muscular activity, and the passive return to repetition when other thoughts intrude. So, and you can see this as little as 15, 20 minutes daily. On the neuroscience side, what happens? There's, again, these were some of the early studies that showed that there's a general quietude that emerged in brain activity, and particular areas of the brains were activated, particular areas of the hippocampus and the amygdala. And in addition, the other spectacular finding that was found was that when we looked at long-term meditators and compared them against controls, that parts of the brain in the prefrontal cortex, which is what differentiates us as humans from every other sort of mammalian creature, is thicker. They're thicker in these advanced meditators, which was an unexpected finding. Now, does that mean they have there's greater neuronal plasticity there? Are there greater synaptic conditions? Again, that's still to be understood. But what has neuroscience revealed? And again, this slide doesn't really show clearly, or maybe it does from back, but up front does not. But basically, when we go through a mind-body practice, what neuroscience has revealed is that the brain, different parts of the brain are constantly being activated in these meditative practices. And it's not that only one thing happens, it's that different parts are responsible for different pieces. So you will go from mind wandering to distraction awareness, to sort of reorientation of awareness, to a sustained focus. Again, every mind-body practice has this sort of thing. You start off with wandering mind, or this monkey mind, as people call it. You become aware, I have a monkey mind. I have a wandering mind. Any of you have done a mind-body practice in yoga, you think about when you're in that downward dog pose, how many things actually keep going through your mind? Like, why am I here? What am I doing? What is the work I need to get done? That person behind me is able to do it way better than me. Reorientation of awareness, and then sustained focus. But our work at the Benson-Henry has now looked at the epigenetic levels of this. And what we've come to appreciate is that when patients, even as little as 8 weeks, we're able to demonstrate that there are changes in specific genetic imprints or fingerprints that are seen to be consistent across different mind-body practices. And again, we're trying to understand this more in greater detail. But the themes that are there are genes implicated in apoptosis, the stress response, and inflammation. And they are enhanced expression of genes that are associated with energy metabolism and mitochondrial function, insulin secretion. We know about telomere maintenance now. There's reduced expression of genes linked to the inflammatory response and stress-related pathways and potential mechanisms for positive health effects. And we wrote a review just a couple years back, sort of exploring some of these mechanisms. Just give you one specific paper that we published just early last year. We found that in inflammatory bowel disease, again, some of these, there's obviously a subjective response of decreased pain catastrophizing and pain trait that we found, again, when patients went through a mind-body program. But also, there were downregulation processes that are opposite in direction in actively inflamed inflammatory bowel disease. So again, these are all becoming important data points for really the next round of studies. Again, not to say that these are definitive, but they've created really compelling pilot data that has allowed us to really think about the funding and think for some of you, hopefully the funding for the next round of studies. One of the key focus that we focused on is NF-kappa B. It seems to be, again, this looks, as some of you know this type of work well, but it's like a hub of like an airline map looks like this, and you can see there are different hub molecules. And one of the key hub molecules is NF-kappa B. Okay. So, what are we talking about in mind-body medicine? Really, it's a really new paradigm of health. Pharmaceuticals are important, surgery, procedures are important, but this is the self-care piece. And we want a balanced sort of three-legged stool. I'll just show you a study that was published by our colleague, Jim Stahl, again in 2015. He's now currently Chief General Medicine at Dartmouth. And basically looked at every patient who had gone through our clinic over the past 7 years and compared them in our internal database at Mass General of similar-looking patients, matched patients. And it was a 3-to-1 match. And we found, again, when we look at 1 year before intersection with our institute and our programs versus 1 year out, what do we find? We find that there is 43% reduction in billable encounters, for intervention patients across all functional categories. Amongst highest utilizers, and even in the most conservative propensity analyses, there was average relative utilization reduction of 18% in functional categories, 24% across clinical sites. This was roughly amounting to on the order of $2,300 per year of savings, cost savings per patient. The end result, this was a retrospective study, so obviously it carries those limitations, so I don't want to overstate what this means, but it allowed us to now do an internal, sort of apply for funds and have received funds to do, even in our own hospital with our own employee population, a prospective study, because obviously our hospital is, because we're self-insured, these savings actually amount to quite a bit, especially amongst those high utilizers. And so we can, the expected range, again, this is where there's a huge range, but anywhere between $640 to $25,000 per patient per year. Again, we hope to have a better clarity around that. But this is really, this study, I received so amazing amount of press in the field, and has actually propelled efforts in multiple institutions, which we've been lucky to partner with as well, including here. So this is it. Nothing happens next. We're here. We have arrived. So what is mind-body medicine? These are, again, just I want to summarize. These are really healthcare-provided rituals. It's about healing power, the examined life. There's a scientific examination of mind-body connection. These are patient-initiated practices and self-empowerment. There are exotic examinations of medical and moral redemption, and this allows that to happen. People are looking for meaning and purpose, and it allows permission for that. And it allows the blurring of boundaries between religious and secular worlds in safe ways for health providers, which is important for patients, it turns out. They want to be able to talk about this with their healthcare providers. Remember, medicine originated from that blurring of this boundary. That's where medicine was many, many centuries ago. We've isolated ourselves from that, and patients really desire that. So building resilience is around these sort of different approaches. This is what we do in our SMART, or Stress Management Resiliency Training Program. We go over these things, and again, people here experience this, so I won't belabor this point too much because you will have direct experience of that from your colleagues here. Some of you may be at this point right now in this talk, thinking about lunch, if you haven't had lunch, but these are examples of actually two different types of meditative practices. I just want to give you this one. So this is where we're located. Again, I wasn't joking. We are at this complex intersection by North Station, where 5 streets meet, and you have the basketball and Bruins hockey stadium literally across the street from our clinic. It is about as stressful of an intersection as you can get, but it is a beautiful place to do the practice. And we are an independent thematic center at M.P.H. We have obviously clinical practice, research, education. We are really studying the ways to combat stress and enhance resiliency. And again, I've talked about this sort of three-tiered process. We're really building awareness of stress and its negative effects, promoting social connectedness, healthy lifestyle behaviors, and obviously elicitation and relaxation response. And what we've developed is this multimodal 8-session program. It really incorporates elements of modern psychotherapy with wisdom traditions through mind-body practices. We do now have a certification program, and again, really allows, and again, as some of you here will be engaged in that. So, but the idea is really for you to be, we want to be partners with you, and really for you to be able to do this work independently. This is just sort of the outline of what that certification process looks like, and I just wanted to so that you have that sense of it's a multi-tiered, and we've hopefully thought through it very intentionally and carefully. And then, again, the work is just starting. I don't want to, again, we have a beautiful signal that we've been able to follow over the past, Dr. Benson's at this work for the last 4 decades, but the last decade has been really quite monumental. But here are the hurdles, and these are the hurdles. Obviously, funding is important. Funding the science that needs to be done. Proving clinical efficacy in specific health conditions, continuing to look at and examine determine biological mechanisms, determining cost effectiveness, overcoming bias, On both sides. We do not want to be like, oh, this is the greatest, everything, follow this blindly, follow this blindly. No, 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 no. That would be doing a big disservice to our patients. We want to be able to really critically examine how this can help in our patients in what specific ways. Creating culture change, broadening acceptability and accessibility in the community. Obviously, this should not be just to those that can afford it or the wealthy or the privileged. And using evidence to convince payers and governments to cover these interventions. And with that, this is my space of just reminding myself of this, my daughter, and what stress reduction can really look like. And somehow we forget it as we get older. But at this age, they're completely our best teachers, it turns out, in reminding us that. So thank you for your time and attention. I'm happy to take 2 questions. Yeah. 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 Right. Right. Yeah, that's a positive view of that story, even as a. But let me give you. I'll give you why. The Relaxation Response book, which he published, he did it at a time when academics at the time it was considered very heretical to publish a layperson book. Now that's like part of your promotion criteria. It's like if you do something for the lay public, but that time it was like the thing that destroyed your career. So he was the fastest professor, one of the fastest to get promoted to associate professor at Harvard. When the Maharishi, by the time he was already promoted to associate. It took him 40 years to get promoted to full professor. So just to give you a sense of what that type of. So yes, yeah.
There have been studies on the difference between extroverts and introverts and how they respond to this because of the introvert.
Yeah.
I'm very inclined not to be very social.
Sure. I'm not aware specific. The question is, have there been any studies looking at extroverts or introverts and how they, how they approach this type of work? Specifically, I don't know the studies. My own hunch, though, is that, again, humans are fundamentally social beings. We are, so even if we're introverted, in general, as we don't do well in isolation, in general. Now, few of us there are always outliers, and there may be a few that do. But in general, as a society, we don't do well in isolation. So I suspect even introverted individuals would be doing, should not be a clinical difference on the clinical side. That would be my hypothesis that I would start, that would be that I would test. But I'm not aware of studies that have looked at that. Other question? Yeah.
I'm a layman, I'm not a medical field, but I just finished the book, The Mind-Body Connection by John Sarno.
Yeah.
It was a life-altering.
Yeah.
Book.
For back pain.
Absolutely.
Yeah. Yeah.
For back pain, I've had my whole life.
Right.
The whole
Yep.
chiropractors, acupuncturists,
Yeah.
everybody else, Bikram yoga.
Yeah.
And, just changed my life. But
Yeah.
his point in there is amazing too. With society, was saying like, where the ulcers used to be in the 70s and 80s, ulcers were the big issue.
Yeah.
And actually society, as it became public, that it was a sort of, you weren't handling stress right, or maybe, the social perception of having ulcers, that the mind actually has changed and shifted to maybe fibromyalgia and IBD and these other things because society didn't accept ulcers as sort of
Yeah.
it wasn't,
Although ulcers, to be fair, it's a great comment. We did learn, again, that it isn't all stress related. So, right, remember, so there was a bacteria, and the infectious component was important to. Now that contributes to why some people do develop overt ulcers versus others who don't. There may be a contribution there, but again, this is why this has to be part of a comprehensive look. Surgeries are great for back surgeries. We just don't know who it's best for, turns out. That's why the response is so heterogeneous, and some people respond beautifully to a back surgery and others don't. It's also why when they've done studies of MRIs and looked at radiologists' findings, and if you were to look at an MRI of someone and it says, oh, that's a horrible back, and then you ask that person, there are enough examples and enough, it's actually not statistically significantly different to find a horrible MRI and report of little pain, a clean MRI and report of horrible pain, and then horrible MRI and horrible pain, and clean MRI and no pain. So it turns out that the imaging doesn't necessarily always correlate with someone's experience of their pain.
But his point was that the pharmacies and drug companies are the ones that are going to be your biggest challenge.
Yeah.
Because there's now pills for everything.
Well, so I actually think they might be our biggest allies, and I'll tell you why. Because it turns out a drug company is interested in making their drug work better. So if they're following our research, and if they actually have, and one pharmaceutical company almost did, but then their own venture capital funding went out of it, pulled out, was the idea that if we create the super drug, which is the drug plus the mind-body practice, it turns out it's better than that. And you can actually, turns out, market it or label it that way, that the only way this drug works is when it's in conjunction with your mind-body practice. Best, that actually is better than the drug alone. And so that's actually, could be, if, again, pharmaceuticals, we could become their best ally. So we don't have to look at them negatively either. Yeah.
Question about your slide on the IPD study
Mm-hmm.
early last
Yeah.
year. And it wasn't clear to me, were you guys measuring actual incident levels, or were you measuring the stress of being worried about IPD?
No, it was their actual, there were different domains of their experience of stress and pain and catastrophizing of pain overall. And these are, again, questionnaires used in other IBD studies that have been used to approve agents as well. Because obviously, like if you have an anti-inflammatory agent, they should have less pain coming out of that. That's one of the ways they'll get approved. Or they should have less inflammation. And again, so these were the metrics that were used in studies that have been used in other studies that have been used for approval of pharmacologic agents. Yeah.
I'm just wondering, as you're incorporating Eastern medicine more into this modality, how much of it is actually incorporating like Chinese epistemology or a whole different conception of medicine, or how much of it is just trying to improve the relaxed response technique with an allopathic medicine?
So it's a good question. So I don't know what, at the end of the day, I'm not, I don't think we need to really have competing systems here in some ways, even though we may think that. It turns out it's about understanding, for me, it's about the human experience. Humans fundamentally are born. Many humans will have illness, they will suffer, have pain, and ultimately they will die. Right? I mean, that's sort of like those are known things that happen to every human. And so the idea here is that for us in Mindfulness is how do we empower patients to be in the driver's seat of their health? Whatever system they do it, but doing it in a thoughtful, critical way. We want them to be empowered. We have taken out the way the medical system operates currently is that, again, it's changing. But historically, it's been that doctors were in power. And if you did not listen to what the doctor said, you were the bad patient. Now we're using language of participatory healthcare, which is a great language. It's just that most physicians don't know what that means. They don't like, oftentimes, the patient that's participatory or who might challenge their opinion. They find that to be the difficult patient. We use terms like difficult patients. Or we say that they're non-compliant, right? I mean, those are languages that we've now, it's very normal language. Oh, that's a non-compliant patient. Doesn't listen to what I said. But we haven't really done justice to the patient. So it's really empowering them with a skill set that they can be really collaborative with us. Yeah.
Would you mind speaking to that phrase where the person gets more benefit with guidance and training as opposed to doing it on their own?
Oh, in terms of the mind-body.
Building a mindfulness practice. And I've heard it from other places too. John Kabat-Zinn says the same thing.
Yeah, I think in a healthcare context, you want guidance, right? So I mean, I'm a healthcare provider. I'm a physician by training. That's my lens is that I'm interested in health, And I'm interested, obviously one person can't figure out all of some health, and so it does require guidance. We fundamentally believe that. We want healthcare providers to be the guides. That's our other fundamental belief. And we wanted to do it in an objective, evidence-informed, and evidence-supported manner. So it's really consistent with all the tenets of what we think good medicine is about. So, yeah, we have to stop. Okay. All right. Well, thank you, everyone, for your attention. And again, really an honor to be here.